Thank you for joining me for this BAA and BTA e-learning module for tinnitus. My name is Beth Ann and I am an audiologist and hearing therapist. I've been working in tinnitus for many years now, I lose track, and my hope for today is to outline for you when and why to refer medically, when and why we should refer for further tinnitus management advice from a tinnitus expert. So sort of recognizing when the first line work needs a little bit more, and then we'll go through some case studies at the end. So when should we refer? Assuming that referrals are coming to audiology from GPs, so this is specifically for people who've been referred from GPs, but actually, as we're seeing more and more, there are now direct access audiology services and direct access tinnitus services where patients might be able to refer themselves, for example, in the private sector. So it's probably worth bearing in mind that people are going to be coming in from different streams. But effectively, if the tinnitus provokes mild to moderate distress despite reassurance from the GP or the first port of call, so it doesn't have to be with a hearing loss, there may not be a hearing loss, but if they're reporting difficulty with or without hearing, and if they are saying that they have any kind of difficulty in terms of distress associated with tinnitus, then they should be referred on. And the idea is that this service, so the service that most audiologists are providing, will provide assessment and support. So this is from the Good Practice Guide in 2009, and obviously this has more recently been superseded by the new NICE guidelines. But it's good to have some context of where we're at with things. So thinking very carefully about that, it means that when patients do come to see us, they can expect a full assessment, and part of that will mean that we need to look for red flags. So the BAA referral guidelines quite nicely outline that we need to refer on for investigation for tinnitus which is unilateral, pulsatile, has significantly changed in nature, or is leading to sleep disturbance. And interestingly, not as a separate point, but they still also list or is associated with symptoms of anxiety or depression. But maybe we need to be a little bit more holistic in our approach, and we're going to talk through that as we go through this module today. So for the purposes of this module, we've looked at the NICE guidelines from quite a few years back. We're not looking at the most recent NICE guidelines, but instead giving you an overview of the basics that are out there, and then encouraging you to go and compare them with the new NICE guidelines. We're also going to consider what the British Tinnitus Association has suggested, and we're going to look at the Department of Health Good Practice Guide. So let's look at how the guidelines are similar or different from the BAA guidelines. So the original NICE, BTA and Good Practice guidelines compared with BAA's ones. Interestingly, BAA says if the tinnitus has significantly changed in nature, and also mentions sleep, whereas the others don't, although the Good Practice Guide does, of course, mention sleep as well. Interestingly, we know that about 50% of people who experience tinnitus will have difficulty with sleep. And if you're only referring the people who have sleep problems, you're potentially missing half the population who may have difficulty with something else to do with tinnitus. So sleep by itself shouldn't be the only criterion that we use for referring on for more specialist help. Then, of course, across the board, we are quite aware of head trauma being quite important. Sudden onset, we know we should all be referring for that. The BTA doesn't really mention that because that's more to do with sudden onset hearing loss. Neurological symptoms, of course, we need to be aware of. And interestingly, neither BTA nor Good Practice Guide mention it. Associated vertigo, we should always be referring for. What I'm particularly interested to see is, because my role is much more therapeutic than anything else, so it's much more on sort of helping people to live with tinnitus. And so I really like that in the BETA guidelines we've got something that says about how troublesome it is, or the effect that it's having on people's lives, because that's ultimately the crux of it. If it wasn't having an impact on someone's life, there's a good chance that they may not be referred, or if they were, just one session would be enough with a little bit of information. But for most people coming to us, it probably is worrying them or having some kind of impact on their lives, and that's really what we're particularly interested in. If we're uncertain of the cause, then of course we should be referring on. And then interestingly, only the Good Practice Guide mentions tinnitus and non-ontological conditions, so any systemic conditions, for example, endocrine conditions, so hypo or hyperthyroidism, or neurological, for example, multiple sclerosis. So a lot of people sort of wonder why you should refer, because if really there's no cure for tinnitus, then what is the point in referring them on for medical investigation? But the truth is that there are some medical conditions where if you treat the condition, there's a good chance of actually improving the associated tinnitus. And that is really the job of an ENT or an audiovestibular physician. So when tinnitus is part of otosclerosis or conductive hearing loss or Meniere's disease, of course, we know that there might be some treatment that can help with that. Anyone who has cerebellopontine angle lesions, for example, acoustic neuromas or vestibular schwannomas, if they are treated, you might find that there's an improvement in tinnitus depending on how the tumor is dealt with, but also depending on what the initial site of the tumor is in terms of size and so on. And then, of course, if people have pulsatile tinnitus, besides just referring on for investigation, it could be that if some of that is managed, then actually they can have an improvement. More recently, people are becoming more and more aware of the role of migraine. And for a while, I think we've known about endocrine disorders and TMJ dysfunction potentially playing a role. TMJ is temporomandibular joint dysfunction. Then the main thing for me when I see patients, because most of the patients who I see have actually come from either an ENT or an AVP, so that medical stuff has all been teased out, although not everyone has had it teased out and not everyone comes to me through that route. So I will always go through the red flags with them just to be sure that we're not missing anything. But really what I'm interested in is how much of a problem is this for someone. And so when we're asking patients about what concerns them, the best way to find out is not to guess or not to assume, but really is to ask them. So when you do ask them, it's really important to really be interested in what they have to say to you. If you ask them and they're talking to you, but you're not really paying attention, or you're not seeming to be that interested because you're too busy typing up on the computer or writing notes, they're going to very quickly get the impression that you don't really want to hear, and they might just stop. And actually, so potentially either stopping and listening, or if you are pressed for time, as we all are in the NHS, if you do make notes as you go, once you've typed up your notes, then stop and summarize it. Questions that might be able to help are things like, when you're most aware of your tinnitus, what runs through your mind? And what you're trying to find out here is, what are their concerns? And quite commonly we'll hear people say things like, oh, I'm worried I'm going to lose my hearing, or I don't know, what if I'll never be able to sleep again? Those types of things. And so that gives you quite an explicit statement of concern, but sometimes it can be a little bit more subtle. You might ask them, is there anything in particular that worries you about your tinnitus? And they may or may not have an answer, but instead they start giving you examples of situations where they're having difficulty. And at those times, it's really important to listen carefully to try to pick out what are the themes here? What are they trying to tell us? And we know what the common problems are associated with tinnitus, and really that's what we're listening for. And then it's about saying to them, it sounds like this is your main issue. It sounds like what you're saying is this. And by summarizing it and saying it sounds like, you are giving them license to correct you if you've got it wrong, which is really important, because only if we know exactly what the concern is can we address it appropriately. So at the audiology level, we should be offering reassurance and information. We should be giving an explanation and some advice on tinnitus. We might use counseling skills. We should use counseling skills, and we might use some CBT skills, but only if you've had the appropriate training and ideally supervision. We should give them some information on using relaxation. If they're having difficulty hearing, we can give them some advice on hearing tactics. We can also fit hearing aids and refer for assistive listening devices. And then, of course, sound enrichment might be quite successful with a lot of people. And a lot of people have actually figured this one out already. But they may not be aware of the range of apps that are available, for example. They might say that they've tried listening to the radio and they really don't like listening to the radio. And then, you have the opportunity to introduce free apps which are available for people to try, which are more natural sounds, and they might find that pleasing. But it's also really important at this stage to recognize that if someone says, I've tried that and it doesn't work, we don't then continue to force that down their throats, because as far as they're concerned, they've tried it. And if you just tell them about it again, they're going to think that you're not listening. So it's better to just hear what they have to say and accept it, and then offer, that might be something that's helpful, or it sounds like it's really good. And then go from there, depending on what they say. So in terms of recognizing distress, it can be quite helpful to have an idea of the prevalence. And the most commonly cited prevalence is the 10%, which is the biggest study carried out, which was in 1989 by Adrian Davis. But actually, since then, the BTA has commissioned a bit of work, and it seems like the numbers are, instead of being 1 in 10, the numbers actually are a little bit closer to 1 in 8. We expect that people will have, about 50% of people will have tinnitus in both ears, which means that you can expect about 50% have unilateral tinnitus and therefore should be referred on for investigation. But the annoyance and the impact of hearing is incredibly different depending on the different people. So in terms of recognizing distress, it's having an understanding of what exactly is associated with tinnitus. So we know that sleep is a big deal for a lot of people. The good thing, and the thing that I often find really helpful to say to people, is that not everyone who has tinnitus will have difficulty sleeping, which means that we know that there is potentially a way to help with it. The risk factors for having sleep problems include having a history of mental health disorders, including depression, emotional stress, working late night shifts, and traveling through different time zones. And unfortunately, it can be very difficult when people are working shift patterns or traveling through different time zones to find a way of working with them to ease the sleep. But often the focus then can be actually not easing the sleep necessarily, but helping them to feel that when they are in bed and trying to relax, that you can maximize the relaxation opportunity, which then helps them to feel like they're getting some nourishment from the time that they're spending in bed. We know that people report difficulty with concentration. Interestingly, people report speech discrimination problems. Often in audiology, we get people coming in saying that they're having difficulty with tinnitus and hearing, and it can sound like it's kind of the same issue. And so what I like to do, and this isn't necessarily the right way, it's just one way, is I will ask people, do they believe that their tinnitus is interfering with their ability to hear? And if they say yes, that's fine. I'm not going to challenge them on that, because that's their experience of it. But often, if they do report that and they have a hearing loss, offering them hearing aids can actually be incredibly helpful. Because if you explain to them that although they might feel that the tinnitus is having an impact with hearing, if you fit hearing aids, sometimes by giving the brain that little bit of extra sound, everything, the tinnitus calms down a little bit. As far as they're concerned, does it really matter which bit is making the difference? As long as it helps them, that's the important thing. We know that people report lifestyle changes. So some people say that things are significantly different in their lives because of tinnitus. And then, of course, they can have feelings of hopelessness and helplessness. And, the evidence is quite clear for anxiety and depression. Sometimes people get a little bit nervous about asking about mood, but most people who are having difficulty mood are perfectly aware that they're having difficulty and actually quite happy to talk about it. So it's definitely worth asking. So how do we figure out who needs more help? How do we know? And the most important thing, I think, is focusing on that individual. There isn't, one person might have what seems to be no difficulty with tinnitus, and someone else will have an incredible difficulty with tinnitus. And the only way that we can really know is to talk to them about it. So our role is to enable patients and to collaborate with them and use their perspective on their lives to figure out what matters to them and how they live. So we're using very much a patient-centered approach, and that's going to be different for the individual, for each individual. So person-centered care requires clinicians to work in a way that supports the patient to be autonomous. We are working towards the patient being able to live well with tinnitus by themselves. We need to be sensitive to diversity, so people have different values, and what they can achieve can be very different depending on the situation they're in. Someone who has comorbid chronic pain is not going to be able to achieve the same in terms of physical activity as someone who doesn't. And values-based healthcare seems to be really, really important, because if it's important for someone that they are able to see their family and interact and have good social communication, then it's going to be important to that person that they can hear, most likely. So it's just about listening in for what is important to that individual. And person-centered care is very much reduced when clinicians or interventions aim narrowly for biomedical risk reduction. This is not simply about red flags. This is about learning to live with something that we don't really know how to make better. So how do we shift from a biomedical to a biopsychosocial model of care? Interestingly, many clinicians believe that we're already practicing in a patient-centered way. And if you ask clinicians, they'll, and a lot of us will say, yep, absolutely, that's what I do. But if you then go and ask patient surveys, they seem to paint a different story. So patient-centeredness in primary care, when you look at the evidence, patients have said what they really want more than anything is good communication and partnership. Still quite high numbers wanted health promotion. Most people want an examination, and interestingly, only a quarter of people want a prescription. So we need to bear this in mind, that if the main thing that people want is good communication, luckily as audiologists, we are actually pretty good communicators. So we just need to hone that communication so that it is focused on the individual and their needs. And the way that we can do that is that we can work in partnership with our patients. And if we're doing those two things, then we're probably on our way to a more biopsychosocial model. So it's a careful and skilled approach. We want to elicit current behavior. What are they currently doing in their lives? What are they doing to cope with their tinnitus? What are their preferences for outcomes, and what are their preferences for treatment options? And these are two different things. Someone might want to be able to have quieter tinnitus, but at the same time be able to recognize that that may not be possible. And so then you need to explore, well, if you did, what would that mean for you? And they might say things like, well, it would mean that I'd be able to sit and read for half an hour. So the outcome is being able to read for half an hour. How they get there is your treatment option. So that may be that they do some relaxation beforehand, that they read in the garden, or that they've got some background sound on to help them to take the edge off the tinnitus. So those are your treatment options. So your options are different from your outcomes. And it's important to establish with the patient their needs for both of those, or their preferences for both of those. So our ideal consultation is an open space where patients are offered accessible information and they're given time to consider their options. It's an opportunity for clinicians to determine what matters to patients, very much within the context of that individual's life. It's collaborative. So we take into consideration the evidence base, which is what we will know, and then we share that with the patient to help them decide what's right for them. It very much is a two-way dialogue where clinicians adopt academic humility. So although we may know the evidence, we don't know that patient's inner world, and we need to respect that they're going to be the expert in that. The decision aid is something that has been developed through some research, which was led by Helen Price, and the Cochrane Review of Decision Aids in general show that there's very strong evidence for them improving knowledge of options. Patients feel better informed and they're much clearer about what matters most to them. There's moderate evidence that it leads to engagement and that decisions are more consistent with patient preferences. So the tinnitus decision aid is available on the BTA's website, and it goes through the frequently asked questions and then what the different options are for patients. And this is very much an evidence-based document that has been developed together with patients. So we're going to have a quick whiz through some case studies. In my clinic, I use the Tinnitus Functional Index, the TFI, which breaks down the tinnitus into these different categories. What I like about it most, though, is not so much the overall score, but rather which aspect, which subscale comes up with the highest score. Because for patients who are potentially finding it a little bit difficult to explain exactly why the tinnitus is an issue for them, it can give you some nice indicators. It looks at things like intrusiveness and sleep, the emotional consequences, quality of life, that kind of thing. And then the HADS is the Hospital Anxiety and Depression Scale, which has been designed for use in outpatient settings, so very helpful, but you could use you can use other questionnaires as well. You will find that if you look at the latest NICE guidelines, there's a little bit more information there in terms of which questionnaires you may choose to use. So this gentleman is a 60-year-old male who I saw, who's got bilateral but asymmetric tinnitus. So he's got a right tinnitus, which is a constant humming, and a left intermittent tapping sound. And it is non-pulsatile bilaterally. It's bothersome and sleep disturbing. The tinnitus is long-standing and it occurred simultaneously with the hearing loss. This is his hearing test. So in our session, he filled out the TFI for me, and the tinnitus comes up as being a big problem, with the highest subscale being auditory, normal anxiety and depression. And his main issue is that he can't hear what people are saying. And when I probed him a little bit more, he said that this is because of the hearing loss and the tinnitus. So it's the main problem. But although sleep was a problem, it's been a problem for a long time. And it's not because of the tinnitus. And I think that's an important thing to establish, because if someone does have long-standing sleep problems, they may benefit from help from a sleep professional, because it predates the tinnitus. So there's probably a little bit more complexity going on. The tinnitus doesn't have an impact on day-to-day life, but he feels annoyed with having to ask for repetition. And I asked him if he was managing his tinnitus better, how would life be different? And he said that he'd be able to hear better. So everything here to me was quite clearly pointing to a hearing aid, which is what we did. So the second gentleman is 61, bilateral sensorineural hearing loss. He's got very complex medical needs. Tinnitus is more noticeable at nighttime, and he has possible panic attacks according to the referral. This is his hearing loss. So he reports tinnitus being a very big problem, and the highest subscale is sleep, relaxation, and emotion. So on 3 subscales, he's getting very, very high scores. He's got severe anxiety and mild depression, according to the HAS. So he reports that he feels that his tinnitus makes his balance worse because it affects his hearing, and then his hearing affects his balance. He needs to take sleeping tablets because of his tinnitus, and it's bothersome 100% of the time. So he can't, when I say to him, are there times when it's more or less bothersome, because I'm trying to figure out the differences between them, and is there anything that we can learn from when it's not so bothersome that can help us for the bothersome times. But he says, it's all the time, and the tinnitus exacerbates an already tricky sleep problem. He says that if he was managing better, it wouldn't be so annoying, and it would mean that he would have a better mood. He feels that he's been robbed of quiet times, and his quiet times are important to him. And his quiet times now only exist when he's taken sleeping tablets. So really feeling that his tinnitus is having a massive impact on his life. And so we agreed that during the day we would go with hearing aids, because he feels like the tinnitus is bothersome 100% of the time, and that might help him to feel like he's getting less bothersome times. And then we're also going to refer on to psychology, because clearly he's having some psychological distress associated. The third case study is a 48-year-old woman who has long-standing left-sided tinnitus, bilateral hearing loss, migraines, and stress. And just recently the tinnitus has become more intrusive. She feels it affects her hearing. The initial onset way back was with many ear infections. She's got lots of family issues. So her daughter lives far away and she visits her every 3 weeks. The patient has been feeling depressed and considering counseling. So interesting how she's been feeling depressed and the tinnitus has become louder and more intrusive recently, when nothing else has changed. So she's got profound hearing loss bilaterally. So her tinnitus is considered a very big problem, and interestingly her anxiety comes up as higher than her depression score, although she's saying that she's feeling depressed. Remember that the HADS is not a diagnostic tool, it's a screening tool, so it's just giving us an indication. Again, tinnitus is very loud and it's constant. She feels her hearing is muffled because of tinnitus, and one of her issues is having conversations. She feels like her head is going to explode. She can't progress at work because of her hearing loss. So that's potentially linking into some slightly bigger issues there. She's not interested in using ALDs. So although she feels like she's being limited by her hearing loss, she's not really that interested in trying something that might help. And she's also not interested in implants. So we spoke about that a little bit more, and I said to her, things are going to be limited in terms of hearing aids and her hearing loss. We could try an alternative, but I didn't think it was going to make that much difference because she already had the most powerful devices that we had available. And so we did try an alternative, and she had no benefit from it. And so we agreed to refer on to psychology because she was having, this idea of not being able to progress at work. It's unlikely that it's just hearing loss that's the issue in a case like that. And it's worth just paying attention to, these big sweeping statements. I can't progress at work because of my hearing loss. Everything is around the hearing loss. And so actually, maybe it's worth considering what else could there be that's impacting on her belief that she's not able to progress. And that might be better explored with someone who has more experience in broader coping, which definitely would be either the well-being services who work with long-term conditions, or otherwise psychology if you're lucky enough to have access. The fourth case study is a 55-year-old female who has constant tinnitus, which is louder in the evening. It's brief, bilateral non-intrusive clicking, but she feels that she can't relax. Sound enrichment was tried, but she's not interested in that, and all she's interested in is a cure. So this is her PTA. Tinnitus session, again, very big problem, normal anxiety, normal depression, more difficult at night. She has no idea how long it takes to fall asleep, but every night is a problem and there's nothing she can do. And she said, maybe I wouldn't be so annoyed if I was managing better. But the main issue is that my tinnitus has not been investigated properly. I need a scan. I'm not interested in management. I'm not interested in coping. All I am interested in is a cure. I don't have a cure. And I handled this in a way that I feel that we came to the agreement together that she should get a second opinion because she felt that she needed a scan. I cannot, in my service, I'm not able to request a scan. And she very clearly told me that she's not interested in anything to do with management or coping, and that is all that I have available to offer her. So I suggested to her, I said to her, this is what our service has available, and we're more than happy to have you along to any of our sessions, but she did not want to do that, and I had to respect that. So she instead decided to go back to her GP and ask for a second opinion. The fifth case study is a 20-year-old who had left-sided tinnitus and she's awaiting surgery for sinus disease. So this is her PTA. Again, very big problem, but look at her anxiety and depression scores, both quite high. And she was telling me that if her surgery is unsuccessful, she would feel very bad because the tinnitus is there all the time. It's worse at night. She's a student and she's losing interest in her studies. She's feeling very low and she would consider self-harming if it didn't improve after the surgery. And the last time she felt like this was 6 years ago. But she assures me that disappointing her family stops her from doing anything to hurt herself. She's very clear she doesn't want to go there again. But nonetheless, alarm bells definitely ringing for me because there is a history of her self-harming. So we agreed that we fit her with a hearing aid until surgery. And in the meantime, she was going to speak to her GP about being referred on to IAPT, or the local wellbeing service. And I also let the GP know that she had mentioned that she was feeling that she would consider self-harming if her tinnitus didn't improve. So please, please, please to keep an eye on her. So here are some references for you and some recommended reading. I'm going to stop there, but I am going to strongly encourage you to read the full NICE guidelines that are now available. The guidelines that I refer to are the older ones, which talk a little bit more about sort of general ideas with tinnitus, but they're not quite as broad or as specific as the ones that are currently out. The reason I haven't spoken about the newer guidelines today is because this module was recorded a couple of years ago before they were out, and I've simply re-recorded it because we had a bit of a glitch with the file becoming corrupted. So please do read the newer NICE guidelines, but consider them within the context of what we have from before. Thank you very much for joining.